Hello everyone, welcome to the nursing world. Today we are going to discuss an important topic, that is a mechanical ventilation in the nursing. So, to the introduction first. It is a process by which the FiO2 is nothing but the percentage of oxygen in the mixture of air is 21% room air or more is moved in or out of the lungs by the mechanical ventilator. This mechanical ventilation is nothing but it is the air which is moved in and out of the lungs by the mechanical ventilator. Using the mechanical ventilator, what the air is going inside, and that is mainly known as inhalation and exhalation. Mechanical ventilator is not curative, and it means of supporting the patient until they recover the ability to breathe independently. This is not like we are going to get back the patient to the normal. That is just supporting features for the patient to get the ability to breathe independently by themselves without any artificial means. This can also serve as a bridge to the longer term mechanical ventilator or until a decision is made to withdraw the ventilator support. A ventilator replaces the spontaneous respiration and ventilations. This ventilator will replace what it is like respiration and the ventilation. Then the ventilator provides the functions of the respiratory muscles, and the endotracheal tube establishes as the patent and unobstructed airways, and the exogenous oxygen source gives a patient a therapeutic concentrations of the gases. This is the introductions of the mechanical ventilator. You can see what is mechanical ventilator, how the machine will be. This is the ventilator machine, and it is being supported to the patient, and they are giving the artificial air for the inhalation and the exhalation. Next, we are going to see the definition of the mechanical ventilator. Mechanical ventilation is a ventilation of the lungs by the artificial means. This is a life-saving treatment to support the patient that are unable to ventilate and oxygenate their own. That is nothing but a ventilation of the lungs by the artificial means. Means we are giving the artificial support for the patient for breathing. It is a life-saving treatment and support for the patient that are unable to ventilate and oxygenate their own. Means they cannot do this means like they can't breathe by themselves. So this artificial means is given to the patient. Next, we will see the next definition. Second definition for mechanical ventilation. Mechanical ventilation is a medical term for the artificial ventilation where mechanical means are used to assist or replace the spontaneous breathing. This is the second definition for mechanical ventilation. Next, we are going to see the goals for mechanical ventilation. Main goals are like achieve and maintain the adequate pulmonary gases exchange and minimize the risk of lung injury. We will achieve and maintain the gaseous exchange, and we will reduce the risk for lung injury. Then the reverse of the respiratory muscle fatigue can be reversed and reduce the patient work of breathing and optimize the patient comfort. So by giving the mechanical ventilator, we will reduce the patient's work, like they will not have any work. The machine will be working for breathing of the patient, and we will maintain the patient comfort and normalize the blood gases and provide the comfortable breathing. These are the goals for mechanical ventilator. Next, we will see the indication for mechanical ventilation. Mechanical ventilation is indicated when the patient cannot maintain spontaneous ventilation to provide the adequate oxygenation or carbon dioxide removal. When we cannot put out the carbon dioxide and take in oxygen, we need the support of the mechanical ventilation. So, acute ventilatory failure, for example, pH will be less than 7.3 PaCO2 greater than 50 mm of Hg. PaCO2 is nothing but partial pressure of the carbon dioxide. So it will be greater than 50 mm of Hg. Then severe hypoxemia, where PaO2 will be less than 40 mm of Hg, and SaO2 is nothing but measurement of oxygen saturation in the arterial blood will be less than 75%. Then implementing the ventilatory failure, for example, progressive acidosis and hypoventilations to the pH less than 7.3, PaCO2 is greater than 50 mm of Hg. Then prophylactic ventilatory support, example, post anesthesia recovery, and reduced risk of pulmonary complication, prolonged shock, head injury, and smoke inhalation. Of hypoxemia of major body organs, example, hypoxic brain, heart, muscles. Then reduce the cardiopulmonary stress, example, prolonged shock, CABG, and other thoracic and abdominal surgeries. Then post-operative respiratory failures. These are the indications for mechanical ventilator. Next, we are going to see the contraindications. That is, absolute contraindications are untreated pneumothorax. Then relative contraindications are patient informed consent, medical fertility, reduction of termination of patient's pain and suffering. Next, we will see the types of mechanical ventilations, that is negative pressure ventilator and positive pressure ventilator. These are the image for negative and positive pressure ventilators, how it look like. So we will go to the negative pressure ventilator. The patient body is encased in an iron cylinder and negative pressure is generated. See, the patients will be enhanced in the iron cylinder as you can see in the image, and now restricted in clinical practice as the limit positioning and the movement of lack adaptability to the large and small body, like chest and all will not be moving, so the positioning will be limited in the this cylinder type of box. So this is been restricted in the present practice. And mechanical negative pressure ventilators, what they will do is like, what are their mechanism is like, extract negative pressure on the external chest as compared to the atmospheric pressure, and that may leads to decrease in the intrathoracic pressure during the inspirations. So due to that, there will be a decrease in the intrathoracic pressure during the inspiration. When they are taking oxygen, there will be a decreased thoracic pressure that leads to the allows air to follow in the lungs. Then that expirations occurs passively. It may be similar to the spontaneous breathing. This is about the negative pressure ventilator. Next, we are going to see about the positive pressure ventilator. Positive pressure ventilators deliver gas to the patient under the positive pressure during the inspiratory phase. This is the how the machine look like, and patients will be getting the positive pressure to the lungs. So the mechanism of this positive ventilators is like, inflate the lungs by extracting the positive pressure on the airways as compared to the atmospheric pressure. That will be forcing the alveoli to expand during the inspirations. That will lead to the expiration occurs passively, secondary to the build up the pressure in the alveoli that escapes into the less pressurized and conductive airways. This is the mechanism. Next, positive pressure ventilators can be delivered in the two forms, that is nothing but invasive positive pressure ventilation, that is IPPV, involves in delivery of positive pressure to the lungs through the endotracheal tube or tracheostomy. See, this is how the IPPV will be working. They will be getting the positive pressure through the tubings. Then non-invasive positive pressure ventilation, that is NIPPV, delivered through the special face mask with the tight seal. It provides breathing through CAPP and BIPA, CPAP and BiPAP. See how the mask is wear to the patient, and through this they will be getting the extracting the positive pressure. The classification of this is the positive pressure ventilator is presently working, because negative pressure, that cylinder kind of things has been eradicated. They are not using it in the present scenario, and so they are using positive pressure ventilators. Factors which terminate the inspiratory cycle reflects the machine type. They are classified as volume cycle ventilators. This volume cycle ventilators, what does that do is like delivers a preset tidal volume which with each inspiration, and inspiration stops when the preset tidal volume is achieved. Most commonly used in adult. This volume cycles, this is used in the adults. Next is pressure cycle ventilator. In this preset inspiratory pressure is delivered. The tidal volume delivered to the patient varies based on selected pressure. In this pressure cycle ventilator, what they do is like tidal volume is delivered to the patient. It may varies, like it may differs, like selected pressure, compliance, resistance factors of the patient ventilator system. Third one is the timed cycle ventilator, in which inspiration is terminated when the preset inspiratory time has elapsed, not used in adult critical care settings. Next is ventilator mode. How this ventilator mode is working is like the method by which the patient and ventilator interact to deliver the effective ventilation are called ventilation mode. Like when the patient is under the ventilator, the interact of the delivery of the effective ventilations are called as ventilation mode. The way the machine will ventilate the patient in relation to the patient's own respiratory efforts. How the patient is related to the ventilator with their own respiratory efforts is known as ventilator mode. The modes are like volume modes, control mandatory ventilations like CMV, then assist or control ventilation ACV, intermediated mandatory ventilation IMV, synchronized intermediate mandatory ventilation SIMV. Then pressure modes are like pressure support ventilation PSV, inverse ratio ventilation IRV, airway pressure release ventilations APRV, pressure control ventilation PCV. These are the pressure mode and these are the volume modes. Hope you understood. Next are like other ventilator maneuvers like positive and expiratory pressure, continuous positive airway pressure, bilevel positive airway pressure, volume ventilation plus high frequency auxiliary ventilations, proportionary assist ventilations, pressure regulated volume control. These are the other ventilatory maneuvers. Next, we will see how the setting of the ventilator we need to see. Like parameters, we need to mainly focus on mode of ventilations, respiratory rate, tidal volume, PEEP level, fractions of inspired and ratio. While setting the mode, we need to see how the machine will ventilate the patients in relation to the patient's own respiratory effort, like how much they can do the respiration by their own. Like usual parameters depends on the clinical condition of the patient, on what condition they has been admitted and why they are been underwent the mechanical ventilator. We need to see that. And next is respiratory rate, number of breaths delivered by the ventilator per minute. Usually the breaths per minute is 8 to 12. Fractional inspired oxygen FiO2, the amount of oxygen delivered by the ventilator to patients. The normal value is 21 to 100%. Tidal volume, volume of gas delivered during each ventilator breath, usually 6 to 8 ml per kg. PEEP, the amount of pressure left in the alveoli at the end of exhalations, usually 5 cm of H2O water level, like 5 to 10 cm of H2. Non-invasive form of mechanical ventilations, like modality that supports breathing without the need of invasive artificial airway. There are two types, NIPPV are commonly like CPAP and BiPAP. CPAP is nothing but continuous positive airway pressure. BiPAP is the bilevel positive airway pressure. This is the thing which we are going to see in negative pressure. Next we will see about the BiPAP, bilevel positive airway pressure. This will delivers two pressures. It provides combination of both IPAP and EPAP. The higher pressure level is inspiratory positive airway pressure, and the lower pressure level is expiratory positive airway pressure. So it will be delivered through the high fitting face masks and nasal masks and nasal pillows used for COPD, like COPD patients with heart failure and next acute respiratory failure and sleep apnea. For this patient, this mask is being used, and also used to prevent the re-intubations. Next, we will see about the CPAP, continuous positive airway pressure. In CPAP, it is a spontaneous breathing at the positive and expiratory pressure. It delivers a single constant pressure during both inhalation and exhalations. Requires only source of oxygen and face masks with an expiratory value that maintains the PEEP. So usually this will be set at 5 to 10 centimeter of water level. In the neonates, nasal CAP is a method of. Next we will see the alarms for the ventilators. We will see it is been divided into higher pressure alarm and lower pressure alarm. So in higher pressure alarm, it will be a secretion in ETT tube and airway, or kinning in tubing, patient biting of ETT, patients coughing, gagging or trying to talk, increased airway pressure from the bronchospasm and neothorax. In lower pressure alarm, when tubing is not connected and displayed ETT or tracheal tube. When the in higher respiratory rate, the patient's anxiety or pain will be increased, and secretion in ETT or airway, hypoxia and hypercapnia. In lower exhaled volume will be like ventilator tubing is not connected, leak in the cuff or inadequate cuff seal. In responding to the alarm, what we should do is like we should check the client, we should check the circuit, check the ventilator setting and alarm limits, replace the filter, remove the water from the tubing. Then we need to check the humidifier settings, for example that is related to the humidity, and check the cuff pressure, and we should consider more ventilatory support for the client. The complication of mechanical ventilations are like airway complication, mechanical complication, physiological complication and artificial airway complication. These are the division of the complication is been divided. In airway complications, we can see like aspiration, decreased in clearance of secretions, nosocomial and ventilator acquired pneumonia. These are the airway complications. Next, we will see the mechanical complication, that is hypoventilations, hyperventilations, barotrauma, alarm turned off, failure of alarm or ventilator, inadequate nebulization or humidifications, overheated inspired air resulting in hyperthermia. This physiological complication, fluid overloaded with humidified air and sodium chloride retention, depressed cardiac function and hypotension, stressed ulcer, paralytic ileus, gastric distension and starvation. In artificial airway, complications are sinus infections are common cause of fever, ventilator associated pneumonia. Ventilator associated pneumonia is nothing but VAP. For preventing this complication, what we need to do is that the number of one way to prevent complication related to the ventilator is to wean as early as possible. Weaning should be started as early possible. So accidental extubation or displacement, monitor the sedation. If the patient is grabbing at the ventilator, you may need an order for more sedation or light wrist restraints as a reminder to keep their hands away from the ventilator. Placement at the lips, then no movement in the epigastric area. Next is like tracheal and laryngeal trauma. If it is there, means we need to see the prevention of accidental extubation. Ensure that cuff is fully deflated before the extubations. Then in Ventilator associated pneumonia, we need to see that head of the bed is up to at least 30 degrees, and mouth care including chlorothoraxide, suctioning and brushing the teeth should be conducted. Then check and assure that the tubes are proper. Change the circuit per protocol we need to do. Then ulceration and infection, we need to give the mouth care, switch side the mouth, angle change and suctioning of the secretions. These are the things we need to see. Next, we need to see for the criteria for the weaning. We should do the careful assessment is required to determine whether the patient is ready to be removed from the mechanical ventilations. We should see that whether we can bring them out of the ventilation to start. In respiratory criteria, we need to see that minute ventilations is less than 50 per liter and respiratory rate less than 25 breaths per minute, tidal volume more than 15 ml per kg, and vital capacity is less than 10 ml per kg. PA or FiO2 is more than 50 to 200 and SpO2 is more than 90 percentage. FiO2 requirement is less than 40 percentage to 50 percentage, and pH level is more than 7.25. And other criteria are like improvement, correction and stabilization of the active disease process we should check, and nutritional and fluid status sufficient to maintain the increased metabolic needs and demands of the spontaneous respiration, adequate sleep, physical strength and mental alertness, stable cardiovascular and renal and cerebral status. Chest X-ray is to be revised for the correctable factors and retreated for the indicated. And other criteria are major electrolytes within the normal range, awake and alert. Then hemocrit is less than 25%, core temperature is less than 36 degrees Celsius to 39 degrees Celsius, adequate management of pain, anxiety and agitation, adequate analgesia, sedation, record the scores on the flow sheets. Weaning procedure like rapid ventilation discontinuation, spontaneous breathing trials, pressure support ventilations, SIMV, other modes of for the nursing assessment should be conducted while the patient is on weaning. We need to see that while on the TPs, the patient should be observed for the signs and symptoms of hypoxia, increasing in the respiratory muscle fatigue or symptomatic fatigue. Observe the respiratory rate, work of breathing. Assess for the accessory muscles, tachycardia and paroxysmal chest movement, breathing, chest contraction during inspiration and expansion during the expiration. The role of the nurse before weaning are ensure that indication for the implementation of mechanical ventilations has been improved. Then ensure that all factors that may be interfere with the successful weanings are corrected, like acid base abnormality, fluid imbalance, electrolyte abnormalities, infections, fever, anemia, hyperglycemia, sleep deprivations, ensuring that weaning criteria parameters are met. Assess the readiness for weaning, explain the process of weaning to the patients, offer ensure to the patients, initiate weaning in the morning. Elevate the head of the bed and place the patient in the upright position. Ensure the patent airway and suction if necessary before the weaning for trial. Then provide the rest period for the ventilator for 15 to 20 minutes after suctioning. Ensure that patients comfort and administer the pharmacological agents for the comfort such as bronchodilators or sedatives as indicated. Support the reinsurance, help the patient through the discomfort, apprehension of the remains which the patients after initiation of the weaning process. Elevate and document the patient's response to the weaning. Now we are going to conclude the topic. Mechanical ventilation uses a ventilator to replace the spontaneous respiration and ventilation. It improves gas exchange and decreases the patient's work of breathing, and it is used to treat the patients who are having acute and chronic respiratory distress. Mechanical ventilations can be a life-saving therapy. However, there are significant risks associated with its use. In addition, patients who are in mechanically ventilators often have the serious pre-existing medical problems and they need to be intubation and ventilations because of the serious acute process. Careful vigilant monitoring or in the depth understanding of the complication of mechanical ventilation and their treatment is essential for good outcomes. See here recent advancement for the neurally adjusted ventilator assisted and pressure support ventilation during the spontaneous breathing trials is critically ill patients. For this reason advancement has been attached in this, so you can go through. So thank you for your patient listening. I hope you understood regarding this topic. Hope it will be helpful for your clinical as well as theory practice. Don't forget to subscribe to my channel. Until next time, see you. Bye bye.